and gentlemen, welcome to another edition of Thoughtful Tuesdays. I think it's my privilege to invite Dr. John Mathai for this edition. Dr. John Mathai is the professor of pediatric surgery at CMC Vellore, one of the very old and very well-respected units in this part of the country. And they have had a long experience with treating burns in children. From what I gather, they have dedicated areas in their wards for looking after burn children. They have standard protocols, and there have been regular interactions, with people around to try and keep things up to date. And so they are one of the few units that are actively involved with this. And I am glad that Dr. John Mathai has volunteered to come and talk to us about this. So without much ado, I will invite him to get on with his talk, and then we can discuss questions and things towards the end of this talk. So, ladies and gentlemen, Dr. John Mathai.
Thank you very much, Dr. Sanjay, for this opportunity. And I thank IAPS especially for giving this opportunity to talk on pediatric burns. And our secretary has done a wonderful job of getting this initiative going. And in particular, I must also mention Dr. Nabil Kadri for his persistence in bringing this particular talk to this stage. So greetings from the Department of Pediatric Surgery, CMC Vellore. This is the building that we are in. We are on the sixth floor in this building, and our burns unit comprises about 6 beds, which is also within the same ward. Now, when we think of burns, burns is as old as the discovery of fire. But if any of us is asked to describe what is a burn, we sometimes come a cropper. Now, this slide tries to capture what a burn is. Burn is a trauma inflicted to skin and its appendages. The usual injurious agent is of a thermal nature. It may be hot, or it can even be cold. And there are various other agents like chemicals, radiation, electrical, and even friction. And the other characteristic is that on histopathology, there's coagulative necrosis when you biopsy the burn wound. Now, to get this all into a little focus, we as pediatric surgeons can easily recognize a typical patient who comes with burns to us. So we have done in our studies here at Vellore, we have noticed that the typical patient is usually a 2-year-old toddler, often male, and it is usually a scald injury which occurs in the home, very often in the kitchen. And the average surface area which is affected is about 20%. And they're predominantly superficial second-degree burns, as you see in this slide. Now, panning out a little bit, what is the magnitude of this problem of burns? And it is a poor man's disease, and it inflicts a significant burden on the healthcare system. We don't have very reliable information or statistics for India, so I'm relying on world statistics, and I will draw your attention to particular Indian statistic that is available. About 5 lakh children suffer burns worldwide. This is a WHO figure. And burns is the 5th most common non-fatal pediatric injury. As far as India is concerned, we only have about 10 lakh people are affected by moderate to severe burns in India. Worldwide, burns is the 11th leading cause of death in less than 10-year-olds. And burns is the 2nd most common cause of death due to pediatric trauma. The overall fatality in India and abroad for pediatric burns is between 10 and 14%. And if you might take as the lethal dose of a burn, that is, causes about 50% of affected burns patients to die, it's about 40% of the total body surface area in India. Now, how can you look at burns? We can look at burns by the depth of the burn involved. This is an example of a superficial burn. It is only a painful reminder for the next 2 to 3 days, requiring you to be cautious in future. And it is never used for estimation of the resuscitatory regimen. In this modern scenario, we must also remember that sometimes these burns are not accidental, but may be a feature of child abuse. So watch out for these burns. This is a superficial second-degree burn, just a diagrammatic representation. You can see that the upper dermis, that is the papillary dermis, and the epidermal regions are affected. These burns are painful like the superficial burn, first-degree burn. This is a partial thickness, superficial partial thickness burn, or second-degree burn. And this is a third-degree burn where it goes, a deep second-degree burn where it goes into the reticular dermis, and the integuments of the skin are also beginning to get a little affected by the burn. And what we know as the third-degree and fourth-degree burns, or full-thickness burns, which definitely requires reconstruction and sometimes even ablative procedures if the particular limb is not salvageable. It is easy to recognize the first 3 categories because there is pain, and it is to distinguish between the second and the third superficial partial thickness burn and the deep partial thickness burn, because the wound coverage will subsequently vary, that we have to exercise our judgment. Now, looking at the pathophysiology of burns, the frame on the left side, all in white, is quite crowded. All I want to say is, to summarize, is there is a complement cascade which is activated. And also there is degranulation of the granulocytes, which produces a cytokine storm, which results in loss of local capillary integrity. And also, once it crosses about 20%, the capillary integrity is compromised almost at a systemic level. In addition, proteins both intravascular and extravascular at the region of burn gets denatured, and they also tend to leak outside the capillary, the intravascular space, and produce a osmotic gradient towards the extracellular region, which results in edema. So what is the consequence? A 10 to 15% total body surface area burn is sufficient to produce... Hello?
Yeah, please go ahead. I think there is some, disturb. I've muted the mic.
Okay.
Please go ahead.
A 10 to 15% total body surface area burn is sufficient to produce shock if not promptly attended to. And a 25% total body surface area burn, it results in a severe systemic response and needs to be attended to with great haste. So we need to make sure that the resuscitation is completed within the first 24 hours. Another concept which may not be so obvious and which is not so familiar, but which I would like to draw your attention to, are the zones of injury at the burn. This was first proposed by Jackson. You can see that the point of greatest injury is a zone of coagulation, and concentric to that, there is a zone of stasis where, because of the interstitial edema, the vasculature and the blood supply is compromised and sluggish. And outside that is a zone of hyperemia where there is intense blood supply. Now, if we do not take particular attention to our resuscitative regimen, it is very easy to make the zone of coagulation extend into the zone of stasis and increase the body surface area affected by the burn and make that region unviable. Now, not all burns require admission. Even in developed countries like UK, it's about 1 in 13 burns that require admission of all the burns that report at the emergency department. The American Burns Association has drawn up some criteria for admitting burns patient. The notable features that those who are likely to go down the life-threatening spiral or those who require some special intervention are those who require admission to a specialized burns unit. So how do we approach a patient with burns, a child with burns? The next couple of slides actually has various headings. They're individual headings which are there for us to sort of develop a little focus. But remember that all of these are running concurrently when we encounter a burns patient and undertake their care, acute care. First and foremost, as soon as the child reaches the ED, make sure that you weigh the child and start a reliable peripheral IV line before the veins collapse. And make sure that you also take all the necessary blood sampling at the same sitting. Thereafter, we assess the area of the body, the surface area which has been involved by the burn. The Wallace's rule of nines do not strictly apply to children below 14. And what we instead use is the Browder and Lund charts. It is, you just have to simply shade the area involved by all partial thickness burns, excluding the first degree burn, which I mentioned to you earlier. And if you remember that the child's head is a big surface area, almost 18%, especially in toddlers, of the total body surface area. And the rest of the body is more or less constant, regardless of the age of the patient. It suffices. And a quick reference point is that the palmar surface of any individual, child or adult, amounts to roughly 1%. Strictly speaking, 0.8% of the total body surface area. So this is helpful to calculate the body surface area affected by the burn to guide your resuscitation. And in the emergency also, it is important to identify dangerous burns, as you can see in this picture. This is a child who sustained a flame burn, which occurred when he played with a hand rub which contained alcohol next to the fire. And it resulted in a kind of flash burn which involved his face. Notice the involvement of the ala nasi, edema of the lips and face, and also there was singeing of the hairs in the nostrils. In addition, he did not have stridor, but he was drooling. And so quickly you can see the IV line that has been started, and also the insertion of the nasogastric tube, which serves as an airway to protect access to the laryngeal inlet in case you have to subsequently intubate it. There may be a role for steroids also in this case, DEXA. Now coming to the fluid resuscitation, this fluid resuscitation is a work in evolution, but was largely brought about by one individual, Charles Baxter, way back in 1967. And it has stood the test of time. The notable features are, it is a crystalloid-based resuscitation because crystalloids are available everywhere easily. There are various ways of going about it, weight-based and body surface area-based. But weight-based is, again, very convenient, as I said, because it's so easy to obtain the weight, and there are other calculations which are also weight-based. And the other thing that I would like to bring to your attention is that the resuscitation starts from the time when the burn was sustained and not at the time of presentation. This Baxter's regime, or which is otherwise known as modified Parkland formula, is a two-part formula. There's a Burns requirement and a maintenance component. The maintenance component is what is based on the Holiday-Sega's formula, which we are all so familiar with. And it contains dextrose, which is very important, especially in children, considering the fact that they have limited reserves and that the burn is a high catabolic injury. The Burns requirement tries to ensure that the patient does not go into shock by ensuring an adequate intravascular volume. Though the original Parkland started at 4 ml per kilogram per body surface area of burn, and for a total period of 24 hours, and this 4 ml per kilogram was divided into 4 rations, we have found that from our own studies in our unit, that 3 ml per kilogram per body surface area suffices, especially if you're giving the maintenance component and additional gavage feeds through the NG tube for nutrition. And what is more, initially when Baxter propagated this formula, there was no way of tapering this prescription. There was no cutoff or a safety mechanism to taper this infusion rate. And of late, and we found that even in our study, almost 30% of patients ultimately ended up with resuscitation-associated morbidity, which resulted in excessive edema in the peripheral limbs and in various body compartments. And sometimes if it is excessive, it can even result in abdominal compartment syndrome. So hence, we have found that the way to monitor this resuscitation is to monitor the urine output, which is an objective criteria which is readily appreciated. And we aim for an hourly urine output of 1 to 1.5 ml per kilogram per hour, which is actually derived from the pooled urine output every 4 hours, which we measure by either weighing nappies or by catheterizing the patient. And if we find that the urine output is more than this 1.5 ml, we start down titrating this fluid formula, starting with the Burns requirement by decreasing the hourly resuscitation by 25%, hourly infusion rate by 25%, and noting what the pulse, the vitals are like. If the patient is adequately resuscitated, the mentation should be good, the vital signs should be good, and most importantly, the urine output should be in the normal range. However, it is, as we are infusing such large volumes, it is important to do the bloods again at the end of resuscitation, at least by 48 hours after the onset of resuscitation, to make sure that there's no anemia, dilutional anemia, or hyponatremia or hypoalbuminemia, which can have adverse consequences. Pain management. Yes, Burns is always associated with pain, except for deep, full thickness burns, where pain, the absence of pain is an ominous sign telling us that the skin is not salvageable, and we might have to go for extensive debridement or ablative procedures sometimes. We as surgeons in the past have been very poor as far as pain management has been concerned. But no doubt, in this time and age, we must remember that we must presume if there is distress, that there is pain. And we need to also appreciate that we need to preempt the pain and make sure that measures are in place well before the pain reaches an unbearable level. Now, there are conventional pharmacological methods, and please remember, since the cutaneous circulation is not reliable and intramuscular circulation is not reliable, the best route for pain medications is the intravenous route. Morphine is recommended, and the other opiate which is now available is fentanyl. Fentanyl lozenges are described. Again, fentanyl administered intranasally also is described for pain relief. Paracetamol is a traditional pain relief, and that is still continues to be a good option. And the interesting thing is nowadays you can mix a number of these medications and non-pharmacological methods and achieve a good response and a good control of pain. Others are ketamine, midazolam, clonidine, and dexmedetomidine, which is an alpha-2 antagonist. And the other thing to remember about pain is in burns, there is a background pain which needs to be controlled by a continuous infusion. So you can opt for a strategy like patient-controlled or nurse-administered IV analgesia using a device which has a basal level of infusion and a spurt, a threshold, a burst infusion for controlling the pain. The interesting non-pharmacological methods are, first and foremost, covered treatment of burns, cooling of burns, so making sure that the temperature is cool without any drafts, and especially when you're doing procedures, you can use distraction therapy, especially with virtual reality, play therapy, make physiotherapy play as part of physiotherapy. You can use music to soothe, and they have understood that even explaining to a child is very useful before the painful, noxious stimulus is applied in the form of dressing change. So this basically summarizes what we have said. First and foremost, establish a rapport with the child and ensure that you explain to the child so that the child participates. And also allow for definite periods of relaxation for the child so that he can recoup from a painful session. And make sure that even dressing changes are mixed with play so that the trauma of the session is reduced. Now, when we encounter a child in the ED, in the acute phase, how do we go about it? We make sure that the area of the burn is washed with a soapy solution. If it's a third-degree burn, we make sure that the extremities, especially the digits, are still viable. We might have to elevate. There might be a role for escharotomies. And as I mentioned earlier, close method of dressings is preferable in most settings, as it decreases pain and infection. We don't routinely employ antibiotics unless the patient is in shock or the patient has previously been treated in a hospital and is likely to harbor a hospital-acquired infection. Now, after the resuscitation is over, we need to assess the burn again. Usually this is in the first 48 hours. And most burns, it is not possible to distinguish between a deep second-degree burn and a superficial second-degree burn. And so they're of indeterminate nature. And this is how it looks at that point of time. So what do? If we look for signs of blanching. If there are blisters, it's obvious it's a superficial second-degree burn and the presence of pain. And we make sure that if these are present, we can expect a good recovery and good healing, epithelialization, by about 10 days. But if it is a deep second degree, we can extend this period for 21 days. But remember that there will be some scar. Now, what are the topical wound care that is available and which we employ in our burns unit? Silver sulfadiazine continues to be popular. However, we must remember that it prevents epithelialization, but it has bacteriostatic agent, and it is also effective against fungus. So it is a good antimicrobial. Now, there is also a water-based gel preparation of silver sulfadiazine, which is very useful on the face as it does not form a crust. And so you can easily wash away and you don't have to rub the deficit and thereby cause deepithelialization. Again, special areas like the hand, we employ covered dressings and make sure that the wet spaces are all covered. About 20% of all the burns that require admission, often the hands are involved, again, in our burns unit. Of late, we have been using Acticoat, which is available, a 10 into 10 centimeter strip costs about 500 rupees. It basically has nanocrystalline silver in a rayon or nylon layer. It is a bilaminar layer. It is not very adherent, and the good thing is you can leave it for 3 to about 5 days on the patient and subsequently remove it with very little loss of epithelium. To use it, it is important that we just wet it with plain sterile water and not saline. And that is how the silver is activated. And it is important to cover it with additional Gamgee pads so that if there is any exudation under it, it will be removed. It is also possible to use Acticoat, make little slits, and use it as with negative pressure if it's a fairly clean wound and you want to promote granulation tissue for subsequent grafting. Remember, especially hands, it is important to elevate the hand and also to do the range of motion exercises on a regular basis, maybe even 2 times a day, and also to employ splints in the position, the functional position, so that the first web space doesn't contract, and so also the MP joints doesn't result in contracture there. Nutrition also plays a very important role because, as I mentioned earlier, there's a high catabolic drive. And remember that this continues, even it can persist for even as long as 2 years and can affect growth. The calorific requirement in burns is about 60 kilograms, an additional 35 kilocals per body surface area affected. And also, we need to give additional protein for the burns. There are various burns supplements that we use, and one easy supplement is eggs. Make sure that the child receives at least a minimum of 3 eggs a day, because an egg has about 6 grams of protein. And so you ensure that the child has palatable forms of eggs. The others which are there is HCCM, is high calorie cereal milk, which is made out of plain cow's milk, cereal, which may be rice or ragi flour, and jaggery, along with coconut oil. It triples the calorific density of milk. Remember, when you use high osmolar feeds, it can result in diarrhea, and sometimes you might have to downgrade the supplementation. We employ continuous gavage feeds. The advantage is, even when the child is asleep, you can continue to give the nutritional supplements. Megavitamin supplementation and iron is also important. Supplementation is important and it is important to keep tabs on the iron, on the hemoglobin, albumin levels, so that if you require to do a grafting, you are not caught unawares by anemia. This is also a very important part of burns management to prevent contractures. And especially for children, where the head and neck is very often involved. When we realize how these burns occur in the kitchen, very often the child is only half the height of the adult carrying a hot vessel with water. And when the child grabs the parent's legs, the whole water tips over onto the child from head, covering the whole head to toe. And so the neck also gets involved, and the neck also suffers all the remodeling, the damage, and the subsequent remodeling with fibrosis that the rest of the burnt surface area is affected with. And if contractures result, they can be proved to be difficult for the anesthetist when we have to go for grafting. So it's important to make sure that you look after the neck purposefully on a daily basis during your rounds by appropriate splinting with collars and also with little interscapular rolls. It's also, as I mentioned earlier, it's important to look after the contractures of the hand and also the major joints. And the best way is to make sure that there is active ROM exercises as far as possible. And if not possible, passive ROM exercises within the limits of pain administered by a qualified therapist. Coming to the definitive wound management, we prefer covered dressings. Amnion was used earlier, but now with all the precautions and especially the risk of bloodborne viral infections, even inadvertently, we have moved away from that, and Acticoat seems to be the choice. And there may be a role for tangential excision up to 10%. Remember that when we excise a burn, there is a big loss of fluid, and that can prove disastrous for a small child. And if it's more than 10%, it's better to use covered dressings and have delayed debridement or slow debridement by the process of the scar getting mulched under the dressing. Palmar wounds, and especially areas with glabellar skin, they tend to be a little more resistant towards heat damage, and we can wait for a good amount of time before we say that we need to do something for them in the form of grafting. Now, at the end of 10 days, we need to assess the burn again to see how well they are healing. And again, you can notice that burns are mixed. So there may be areas which are waxy and deeper, but the bigger blanching areas which bleed are actually likely to heal, but with scarring. And as long as they do not involve big major joints, we can do covered dressings with Acticoat, provided infection is not an issue. Now, scar management is also a very important part of burns, which extends after the patient leaves the burns unit. And it is a good thing to remember, once burnt, you are scarred. There may be very little physical scarring, but there is an emotional scarring as well, which we need to address. And psychological strategies are also appropriate for the rehabilitation of the patient, especially as they return to school. Now, how can we manage the cutaneous scarring? So the scars may involve important areas, some very cosmetically important, like the nipple in this child. And especially if it's a girl child, you need to take particular care. And One of the things is Sika Care, which is a silicone-based gel sheet, which you can leave attached on the scar, applied to the scar. The basic principle is that the scar needs emollients and it requires pressure, a constant pressure, which prevents it from becoming hypertrophic and subsequently becoming a keloid. Scar excision in non-essential areas are to be done only once the physical growth is complete, because there will be quite a bit of remodeling and the scar can migrate as the child grows. But if it involves a major joint, it needs immediate, more urgent redressal, usually after about 6 months down the line after sustaining the acute burns, once we know we have employed passive measures for ensuring good function of that major joint and no further progress is present. This shows the wound, affected wound being dressed with Sika Care, which we can leave on for a week. And once it becomes once it becomes opaque, it is time to remove and reapply. We can also use pressure garments, but of course, in a growing child, the life of this garment is limited. And plus, in our climate where there is a lot of sweating, there can be difficulty in maintaining these garments. But this is also another option. Now, preventive measures, as I mentioned earlier, once burnt, scarred for life. But how can we prevent? We need to remember that most of these burns occur at home in our country. So we need to especially move people away from cooking on the floor. It is surprising to understand how, it is surprising to note how understanding toddlers are. And if you instruct them to keep the way clear from the kitchen to the dining area during service, they very well comply, and with a sense of seriousness. And keeping flammable articles out of reach, we need to also make sure that there's legislation. And in fact, in the US, the current burn, which in the pediatric age group is only about 14%, they do not see huge burns. And that is largely because of legislation which controls the temperature of heating devices at home and also ensures that electrical circuits are protected and so on and so forth. There is a big role for school education programs, and I think we need to address that, because once a child is educated, he or she is educated for life. And one catchy slogan can catch, or a jingle can catch the attention of the child, and it'll last his or her lifetime. One such jingle is stop, drop, roll, cool. And I'm sure the children will, you can engage them in the drill and say that this is what you need to do if ever your clothes are on fire. And you can also do it for some other person who is on fire and whose clothes are on fire. Thank you. I also, just before I conclude, I must say that each of these headings that I've dealt with, there's a tremendous amount of work to do. Pain management, one of the things that we need to do further work in. Recognition of a superficial second-degree burn from a deep second-degree burn. Now, traditionally, we have been using a trained eye, but with the present AI, maybe there is an option for dealing with it. We also need to look at other dressing material to resurface the wound. And so far, we have been able to synthesize the patient's own skin, because skin, especially if you have to graft, skin is a premium, it's not easily available. And the graft donor site is also a superficial second-degree burn. So you're actually adding to the body surface area, which is burned. So we need to work on all those. So there is a lot of potential areas for further research and development. Thank you.
Dr. Mathai, thank you very much. That was a very, very succinct, very clear, and very practical way of how burns have to be managed, and the issues, I think, of pain relief, of emotional support, of continuing education, and the things that people usually forget in the heat of trying to manage the acute burn, I think are things that you have highlighted, and those are extremely important things. I will open it for discussion. There are a few questions on chat that we will take, and then if whoever wants, just raise their hand and you can come online. There is a it says KSK. I'm not sure of the full form. We never use closed dressings, as daily dressings is never practical and is associated with more infection. We advise daily bath and silver sulfate diazine application up to 2nd-degree burn heal very well in 7 to 10 days. Deep 3rd-degree burns dressing is given as and when required, not always. There seems to be a difference in the way that these are approached. They seem to be more emphasizing on open dressings than closed dressings. I guess it's just another point of view. Would you like to comment?
I think one of the things is, pain is an important component. And I agree that closed dressings are expensive. I'm not denying the thing. But, you can have amnion as a closed dressing, provided, you get clearance from your hospital sources and you ensure that there's no bloodborne viral spread. If you minimize the risk of that. So that is something. So, I mean, traditionally, we have not addressed pain adequately. So that's one thing. So I do agree that it is expensive. Burns is an expensive process.
Okay, yeah.
And that's an alternate way of addressing this problem.
There are a couple of questions about collagen dressings, about, how good is it? Where would you actually use it? In which degree of burn? And so a little about that. I think that seems to be
I think collagen dressings, again, for the superficial 2nd-degree, they are all right. So actually, you can use just about anything for these superficial 2nd-degree burns. But once it goes to the deep 2nd-degree, that's where, even the collagen begins to lift off. And as the eschar lifts off, the collagen also comes away. So that's been our experience. An infection can set in underneath any of these. So you have to be on the watch for that to treat appropriately. Like once infection sets in, you need to make sure that it is medicated. And probably there again, silver sulfur diazine, takes the cake along with the intravenous antibiotics, appropriate intravenous antibiotics.
I think Dr. Swati, she says, I work in a government hospital and will use antibiotics in all burns. Is it necessary?
We were initially using that. Like every burn who came into the ED, we started off with crystalline penicillin and antibiotic cover. But what we have realized is that burns, even though they are febrile, especially major burns, it's not necessarily sepsis. So if you find that because the thermoregulation is also affected by the burn injury per se and all the cytokines, it resets the thermoregulation. So what we follow is that if there is consistent spikes more than about 101 °F, we take a dressing, a blood culture, and then subsequently start on antibiotics. Empirical to start off with, and then subsequently specific once the culture reports are ready.
Again, I think some more. Yeah, please go ahead.
So we moved away from routinely starting them on antibiotics. We wait for the fever.
It's again, I think about collagen dressings and how plastic surgeons are using it early under GA. So again, it's the same. You mentioned the same thing, saying superficial 2nd-degree, whatever you use, it's fine. Then it is again about QT cell dressing. I'm not familiar with that.
Sorry, what was it?
QT cell dressing. It says CUTICELL.
I suppose, is it something like Gelonet with,
Dr. Swati, are you online? Do you want to come and
oh, Bactigras?
is that practical? I don't know.
Yes, sir, it is a paraffin gauze.
Ah,
Okay.
Normally, so I just want to know whether we normally in government hospital that is available. So I use that QT cell dressing. Normally contains the paraffin.
yeah, like, see, a little bit of an oily dressing, which doesn't, I mean, the main idea is that it shouldn't get adherent and deepithelialize the wound. So, like you can use something which has a little oil, but preferable not on the face. That is all that I have to say, because, when you try to remove the oily base, then you lose epithelium as well. But it's better that it's a medicated oily dressing, if at all. So that's why silver sulfadizine scores.
Dr. Sujay Pal, it says in
Okay, thank you,
second
sir.
degree, we sometimes dress with normal saline and use liquid paraffin, Gelonet, and close dressing. So that's they are happy with that, is what they say in a government hospital setting. A little bit, I think, about electrical burns. I think Vinay had posted that.
Yeah.
How would you, I mean, anything?
Yeah, electrical burns are usually in the adventurous young teenage boy. They either flying kites or trying to sometimes even tap electricity illegally for something at home, and they don't realize what they're playing with. It's a deadly injury. And what happens is that the cutaneous aspect of it looks very docile and benign, but there is a devastating injury which is subcutaneous, involving the muscle compartments. So in effect, you have to watch out for compartment syndromes. Acutely, you need to look out for cardiac arrhythmias. There can be even spinal cord injuries because of the conduction going into the spinal cord. And sometimes, very often, the child is thrown. And so you can have orthopedic injuries. Plus, in addition to this, there is at the entry and exit point, there can be compartment syndromes, myoglobinuria, which results in acute renal shutdown. So you need to, start them on aggressive alkalinization and hydration so as to prevent the kidneys from shutting down using a crush protocol which you use in polytrauma.
Yeah, I think we have had a couple of these, people putting their hands on electrical wires. It is, there are limbs lost and people have gotten very, very sick from them. A couple of questions I had. One is about, suppose you have somebody with a facial burn. You showed a picture and you said that you usually put a nasogastric tube down and that helps you guide subsequent intubation if required. I was a bit curious about that. And if you have somebody who has got a burn, a flash burn or a inhalation burn, what is your threshold to intubate? Would you intubate somebody a little early, or would you wait and then see and then do a tracheostomy? What is the approach
The
to?
threshold is for intubation is early, provided there is signs of stridor. We watch out for that. So that is the thing that tells us that this burn is going to result in airway compromise. So that at the first instance of stridor, intubate. And we give all of them at least one chance with intubation and ICU care, because it is an expensive proposition in us, unless, of course, the parents say, go all out.
Yeah. The other thing that sort of caught my attention was you said that 50% mortality if you have 40% burn. Is that what you meant by that first slide? That
Yes. Basically, if you have a 40% total body surface area, about 50% you do expect them to die. But of course, you can have, you can push that threshold. We have had people who have survived even 80% burns. So they are the exceptions.
okay. That's what I have written here. Does anybody else have any questions or comments that they want to make? Please raise your hand, unmute yourself, and just come online and speak.
I think there was a question about enteral feeding during burns.
Yes.
It is important to start it off as urgently, as soon as possible. There's no role for delaying the thing. Only thing, be conscious of the fact that enteral feeds also contribute to the resuscitation associated morbidity. So keep watch of the urine output and make sure that you down titrate the IV fluids. At least enteral fluids don't rush in that fast into the intravascular volume.
Any other questions? Any IV access and extensive burns, central lines through burnt areas, is that acceptable? Is the question?
It is acceptable if it is done immediately, as soon as the child comes. Remember, burn is actually a flame and you are sterilizing the skin and all that area. So if there's no other place, it is accessible, acceptable to do that.
Okay.
But the main thing is to get a reliable peripheral line. It's not a central line which is important.
Okay. Duration of parental antibiotics. How long would you give them once you start them?
Duration of parenteral antibiotics depends. Like what we look for is a defervescence of the fever, and say about 48 to 72 hours. If the patient is defervescent and there's no fever, then we need to think of down titrating, unless you're thinking of grafting, where you need to keep the bed free of streptococcus, staphylococcus, and pseudomonas. Otherwise, your graft will get eaten.
There's a question on tangential excision. What are the indications and when would you do that?
Tangential excision, especially, for even 10% burns, can be quite devastating. I mean, can have devastating consequences if we attempt a tangential excision in a toddler. So you really have to think much whether you need to do that. The reasons against tangential excision is it is very difficult. I mean, it's probably indicated at a deep a third degree burn, but definitely not in a deep second degree or an indeterminate burn. Because you are losing the viable skin appendages that can subsequently surface the burn with epithelium. So it's a fine balance, and tangential excision can cause the child to go in shock. We have lost children even recently where we had a child who had a hand burn, and we thought we should cover this hand burn because it is a vital part. And then we attempted excision, and then that proved to be a disaster.
Yeah, no, I think
and again, cosmetically, tangential burns are not great subsequently because you lose all body contour.
Oh, okay. No, I think part of the problem is that a lot of the stuff that we read is basically an adaptation of what the adults are using in their burn management. I think the part that you have highlighted is that a lot of things are different and we cannot just directly
Yes.
adapt. And all these things, I think tangential burn excisions and things are all the things to do in adult burns. And I think I think the fact that you're advising
adult
caution,
burns, like sometimes if it's a small hand or whatever, like they even go for flap cover, but that may not be possible in children. Of course, if it's an isolated thumb burn or something, you can attempt that.
Yeah.
But you have to be very, very selective about how you choose the treatment. But this is the usual run of the mill.
Sure. Is there any indication for vac therapy, vacuum dressings?
Yes, especially if you find that it's a very large burn and you want to promote granulation tissue, especially if it's a deep second degree with a lot of exudation, or if it has become third degree, you want the granulation tissue, you can do vac burns at 150 mmHg suction. And you can put it even under Acticoat if necessary, but usually those burns are so large that it will be very expensive to do an Acticoat dressing. Rather, use large gauze pieces under which you put these suction catheters and with Gamgee over.
So what is your for the when you do these change, because from what I can gather, most of your patients are under close dressings. So when you
Yes.
change the dressings, what frequency and what kind of analgesia do you use around the time of dressing for that purpose? Because that's again that's a challenge that we face.
Yes. So what we have employed is nitrous oxide in an older child, because you can use a halter and it is absolutely safe. The mixture is such that there's 50% of oxygen, and the child can never get so terribly anesthetized that the child slips into deeper thing. But what we use on a routine basis is midazolam and ketamine. But that prevents you from continuing the nutritional garbage feeds prior to the administration until consciousness returns. So it's a bit of a trade-off.
Yeah.
And of course, like the non-pharmacological methods are interesting. So we can employ that along with other adjuncts. So those are, those mixes are something that we need to sort of maybe even use a randomized control trial and see how they work. So there's scope for trials.
Sure. So I think one last question about hyperbaric oxygen therapy, and after that, I think we will call it a close. Have you had any experience using it in burns?
No, we haven't had any experience with hyperbaric oxygen therapy. Sorry.
Okay. Any other questions? Does anybody else want to come online, comment, or share an opinion or a question?
Sir, Nabil here, sir.
Yes, Nabil, please go ahead.
Yes, Nabil.
Yes, sir. Hello, sir.
Right.
Sir, actually, just a small bit, if you allow me, I'll talk about collagen, sir.
Sure. Please go ahead.
What I have noticed, sir, I did a lot of collagen. In fact, in my stint in Narayana with Dr. Vinay and Dr. Sanjay Rao, they really pushed me towards doing this. And when I've come to Hyderabad now, I'm in fact doing a little less of collagen. What I have noticed is majority of the burns we get are scalp burns.
Yes.
Majority of them are scalp burns. And in the OPD practice, I am only directing towards OPD people who do a lot of OPD practice, general practice. You get a lot of scalp burns. So the question comes for collagen versus using any ointment. As you have rightly pointed out, be it a scalp burn, superficial secondary burn, you use collagen or you use an ointment, I think at the end result is more or less the same. So it depends on what you want to give. Collagen, the advantage is once you do the dressing, you leave it and we can kind of forget till it comes off. With regard to ointments, maybe the patient will have to put every day. So I think this is a point we can leave it to the parents as a choice. Want to apply it once or you want to just put a collagen and leave it. That disadvantage of collagen will be, not disadvantage, but will be that the child will have to go into the theater and it will be under anesthesia. But I think that is one very good, they will be free of, applying ointment all the time. But I think end result is the same for all. And collagen, one thing we have to very well tell the parents is when it's coming off, it becomes discolored. So what I had noticed is parents, they become very scared when the collagen is coming off. So I think we should just warn the parents, don't worry, this is how it comes off. And I think the results with collagen are beautiful, as with any other ointment which you would be applying. One more point, like today I saw a case of a full hand burn. Do we use collagen in that? Because that can cause constrictions. So one thing I would like to ask is, can we use circumferential collagen? I would most probably not, and I would most probably put something like a stamp collagen. Could you help us on that as well, sir?
Like what we have found is that it's better not to use collagen on the fingers at all, because even if you use stamp collagen, they can overlap and then it becomes a sheath which almost resembles an eschar. So it's best not to use collagen on the digits and use it on a wide area if necessary. The only other thing about, as you rightly pointed out, there's a element of coagulum under collagen or amnion, which people get worried about. And if there's no fever, that is something, whatever form of covered dressing you use, if the child has fever, they need to report. And the policy that we follow is we have now over the last 7 years or so, we have a Burns nurse, we have Burns therapist, Burns nurse for more than about 10 years, almost 14, 15 years, we have Burns nurses. So they come and look after the dressings, and we ask the patients to report on every OPD. So then they are reviewed to see if the dressings get soaked, how the collagen is, and if there is any fever, regardless of when the covered dressing, collagen, amnion, or say Acticoat, they need to come in so that we can remove the dressing. So a temperature more than 100.8 is a warning sign which the parent should not ignore and come back, because sometimes we've had to admit them. And the good thing with this kind of a strategy is nowadays we are also seeing that the amount of admissions are coming down. So if you have people with trained eyes who can detect these things, you can manage a lot on an outpatient basis.
Thank you, sir. Thank you so much.
Dr. Mathai, any other questions? Otherwise, we shall call it a day. Yeah. Right. So, Dr. Mathai, thank you very much. I think that was a very, very crisp, very clear presentation. It's I think it's of practical value, as well as value for students who are writing their exams and things like that. So I think from both points of view, it's been very good, very clear, very precise. And I thank you very much for your time and for the effort going through to come and make this presentation with us. So thank you very much. And good night, all of you. Our next meeting, next presentation actually will be on 30th, which is Monday, and it is from Dr. Michael Harrison of the fetal therapy fame. So I would request most of you to come online and listen to that talk. It's part of the, it's not on Tuesday, it's on Monday because of the sort of time differences and requirements. So anyway, I will send out messages a little later. So ladies and gentlemen, thank you very much. And thank you, Nabil. You had mentioned earlier on and your presence was missed when we started. So Dr. Mathai,
Yes, sorry, sir, I got stuck somewhere, sir, but I made sure I came. So yeah, this is
I think
topic very close to my heart.
Dr. Mathai made it a point to mention that you pestered him till he came and spoke. Yeah, thank you very much. Thank you.
You were persistent, and thank you, Nabil. Otherwise, this talk wouldn't have happened.
Oh, I think I must acknowledge Nabil's participation and contribution for these, because I think he has, though even after he's left us here and gone back to Hyderabad, he's remained in touch and is really helping out with organizing all these things. So I am grateful, and thank you very much, Nabil. Thank you.
Thank you for the opportunity, sir. It's an honor to help to work with you, sir.
Right, ladies and gentlemen, good night. Good night, and
Good night, everybody.
See you all a little later. Thank you. Bye-bye.
Bye, sir. Bye-bye.